Let's learn how to fill in medicine history template. This is an outline for case write-up. First of all, we'll mention patient identification data, which includes name, age, gender, registration number, race, religion, marital status, occupation, informants, date of admission, date of clerking. I often skip these two. Then comes main complaints or reason for referral. Remember that you do have to mention each and every complaint in chronological order. In this patient, first complaint is frequent urination and burning, micturition for 10 days. Second is elevated blood glucose levels such as 600 milligram per deciliter. Then comes history of presenting illness. My patient is a known case of diabetes. Since last 8 years, she complained of excessive urination with burning micturition, which resulted in soiling of her clothes and bed sheets. One day prior to admission, patient had to change 4 diapers in 12 hours. Her urine had orange or red color due to pervaginal bleeding. It was associated with tingling and burning sensation of feet. Her attendant reported of weight loss, which she had when she was admitted. No complaints of reduced vision, wound, no history of stroke. She also reported blood glucose levels of 600 milligram per deciliter. She was administered IV injection, but it had no effect. She also complained of shortness of breath. On next page, past medical history has to be mentioned, whether she is hypertensive, diabetic, asthmatic. In this case, she is non-hypertensive and has no other chronic illness. She is not allergic to any drug. Past surgical history. In this case, it is insignificant. Drug history. If the patient is using any drug, we do have to mention that drug name, dose, and the time duration from which she is using. Then we mention socioeconomic history. For example, we'll write down she lives in her own house with 15 members in it, out of which 3 are bread earners and 12 dependents. She uses filter or bore water, whatever water source she has, and the house is well ventilated. Then here we mention family history. She had no family history of hypertension, tuberculosis, and other chronic illness. In physical examination, we start from general physical examination. For example, my patient was lying supine in bed. She appeared weak and lethargic with cannula attached on her right hand. She was vitally stable, well oriented in time, place, and person with GCS score of 15 by 15. Systemic examination. We rule out each and every system. For example, in CVS, we'll write she had elevated blood pressure with no palpitations, no added heart sounds. S1 and S2 were normal. In respiratory system, we'll mention it was not significant in this patient's case. Renal or KUB, kidney ureter bladder, includes frequent urination and burning micturition, which is an important finding. Central nervous system, it was intact. MFS, musculoskeletal, was intact as well. She had no joint pain, no rashes, and allergies. Here comes provisional diagnosis and differential diagnosis. This diagnosis is actually made on the basis of the symptoms presented by the patient and what we are suspecting. In this patient, we concluded that she might be having diabetic ketoacidosis. Then we write discussion and supporting evidences for our diagnosis, which includes elevated blood glucose levels, elevated blood pressure, UTI, for which we'll go for CBC, complete blood count, to evaluate for infection, frequency, and burning micturition. In this page, we'll outline relevant investigations done with reasons. For CBC, complete blood count, which ruled out leukocytosis, which means increased leukocyte count, urinalysis, positive for leukocyte esterase and nitrites, which mainly indicates UTI. Urine culture, positive for E. coli. ABGs, arterial blood gases, which rules out metabolic acidosis with a pH of 7.2, which is less than 7.35 to 7.45, which is a normal range. State results of investigations done so far with your interpretations. The patient has diabetic ketoacidosis (DKA) with concurrent UTI. Elevated blood glucose levels, metabolic acidosis, and electrolyte imbalance are consistent with DKA. Positive urinalysis and urine culture confirms the presence of UTI. Identify problems, management, and progress of patient. DKA management, IV fluids, insulin, electrolyte replacement. UTI management includes antibiotics, ceftriaxone, azithromycin. Electrolyte monitoring is done. Progress portion states patient showed improvement in her symptoms over next 48 hours with resolution of metabolic acidosis and electrolyte imbalance. Prognosis and outcome. Patient's prognosis is good with expected full recovery from DKA and UTI. However, she will require ongoing management of her diabetes and regular follow-up appointments. Discharge clinical summary. Patient was discharged after hospitalization with follow-up appointments with her physician. Discussion includes case highlights importance of considering multiple diagnoses in patients presenting with non-specific symptoms. Patients' DKA and UTI were managed effectively.